So before we get started, I just want to, since we're starting a new year, this is our schedule. We meet every fourth Tuesday of every month, except for December. We'll take a time off there. So fourth Tuesdays at 5:30 p.m. Pacific time is when we have our meetings to talk about HIV treatment research and other things that relate to HIV and research. And so if you are interested in getting onto our email list, please just send me an email saying you want to join it so you get the announcements for all of these. You can also check our Facebook page. I always put them up as an event on Facebook, so you can see it that way as well and follow us that way. And also, just since we are going to be talking about COVID, I wanted to remind you all that we do have a COVID study for people who have tested positive for COVID in the past 5 days. It's called Active 2, and it's looking for treatments for the coronavirus. And so we're going to be talking about vaccines tonight, which is more about prevention, but realize that there is treatment research going on as a part of the Operation Warp Speed that you may have heard of. So if you wanted to find that, no matter where you are on this earth, riseabovecovid.org. So if you're in the continental US and you know a friend who's just been diagnosed with COVID, why don't you send them that website? It has lots of information, but it also will tell them where the study is being done locally in their area. So riseabovecovid.org is just something to keep in mind. So our brief outline for tonight, we're going to talk about the fight to include people living with HIV in these COVID vaccine trials. And we're going to do that with Jeff Taylor and Lynda D. And then I'm going to let Anna Wald introduce the Novavax Study that she is a PI for. And then we're going to go into what we know about the COVID vaccine and HIV positive people so far, and maybe even get into some new research data about HIV and COVID. And we're going to really wrap up things with the Q&A with Dr. Bender Ignacio. So that is the rough outline of where we are. So, but before we get into with Lynda and Jeff, I just wanted to give some very brief, very simple virology of the SARS-CoV-2 virus. So it's a part of a family of coronaviruses that includes the SARS and MERS virus. It's a single-stranded RNA virus, and that's important for us all to realize because a single-stranded RNA virus means that it has a very high rate of mutation. And that is one of the things that we'll probably end up talking about tonight. It's also made up of 4 proteins, and they label them S, E, M, and N. And the S is the one we're going to worry about. But the N and the M there are matrix and nucleoprotein. The E is the envelope protein. But the one that you probably have already heard about is the spike protein. And that spike protein is how the virus attaches to our cells and fuses with our cells and gets its sort of viral components into our own cell and infect the cell. So the spike protein is really where we have a lot of the focus for the vaccine research that we're going to be talking about. So this is a very succinct look at the vaccines that are in development under Operation Warp Speed. The first 2 are the Moderna and the Pfizer, the mRNA vaccines, and that's what has been currently rolled out into the US and around the world. And then the other 4 are in various states of research, and we're going to find out more about them. But these are the 6 that I know of that are being worked on currently under Operation Warp Speed, which is through the federal government. The mRNA virus vaccine works in a very interesting way if you didn't really understand it. So M stands for messenger. So what we are doing is putting some messenger RNA for the spike protein of the coronavirus, injecting it into the muscles, into muscle cells, and then those muscle cells can read the mRNA and they make just the spike protein, and that creates the immunogenic response in the body and makes the antibodies, and that's what protects us when we are vaccinated from the virus. I just want to kind of give this as a very brief introduction. So I have to admit, over the summer, there was a lot of activity going on around the vaccine, and then it was towards the end of the year here, and I was surprised to see that the NBC Nightly News had this story on its website, which was about the fight to include HIV positive people. And I thought, oh, this is great. So it was the end of the year. I just started to read it. And lo and behold, when I read the very first paragraph, When Jeff Taylor, a longtime AIDS advocate and survivor, learned about clinical trials for the new COVID vaccine in his hometown, Palm Springs, he leapt at the opportunity. I always wanted to be the first person to try something, he said. And since I knew Jeff, I thought, whoa, this is a very prescient article. And so, Jeff, I wanted to start off with you. And I have your picture there. And so for everyone to know, Jeff is the executive director for the HIV Positive Aging Research Project in Palm Springs, and he's also a member of the AIDS Treatment Activist Coalition. And so, Jeff, why don't you tell us, what was it like getting involved with that study?
Well, it was exciting because I wanted to, just like I did with HIV, the way I got access to treatment was to put my body on the line and be a guinea pig in clinical trials. Than what I do, and I'm very invested in that. And I wanted the opportunity to do so here. And I called up the local research site, told them I was interested, went through the screening process, and then we got to HIV. And I told them I had HIV. And to my surprise, they said, "Oh, we can't accept people with HIV." And I questioned the poor study coordinator, who was just reading what's been given to her, right? But of course, I grilled her and said, "Why is that?" And it's like, "Well, I don't know. It's in there." And I said, "Well, it's not supposed to be. I'm an HIV advocate, and we've been assured by people at the NIH and FDA that we're supposed to be included in these trials." He said, "I don't know. This is what the sponsor is telling us." So that's when I, got on my computer and contacted Lynda, another activist, and said, "This just happened. What's going on? Because we don't think this is supposed to be happening." And then Lynda sprang into action because she knows, people both the FDA and NIH firsthand, and got the ball rolling.
And they didn't say anything to you when they said that you were excluded? They didn't say, that they had any idea that maybe that was going to be changing? They just knew that you were excluded.
Right. Huh. And we found out later that we hadn't been initially, and at some point it got inserted into the trial without people knowing, people at the NIH and FDA.
Right. Yeah. And because I remember just right before that, in your news and your email hit, we had just had all of these videos with Tony Fauci and with Carl Diefenbach, both of them assuring us that HIV positive people were going to be included. So we got Lynda involved. And folks, if you don't know Lynda D, she's the co-founder and executive director for the AIDS Action Baltimore. And she was also the former chair, and she's still a current member of another group that you might be interested in, the Fair Pricing Coalition. And I love the end of the article that I was just quoting earlier. This is Lynda's self-description. "I'm a pushy old broad, and I've been doing this for 33 years. People know me, they trust me, and they're often a little afraid of me because I'm this East Coast battle axe, and I say what I think." Lynda.
Who, me?
Yes. So,
hi, everybody.
Hi.
Hi, Lynda. I can relate to that. Say what you think.
Oh.
So, Battle Axe, what do you do when you hear stuff like this? How do you know what to do?
As you said, I checked in with Carl Diefenbach from DAIDS way before this, and we were assured that people with HIV were going to be included. So, I never gave it another thought. And, Jeff was like, "Well, I found this on clinicaltrials.gov and showed everybody the HIV exclusion." And so, that was like a Saturday night. And Sunday morning, I emailed Carl from DAIDS and was like, "What's up with this?" And I know him for years, and that really makes all the difference. A lot of this is who it just is personal relationships. And he got right back to me, and he was like, no, from what he knew, everything was fine. People with HIV were included. Now, what you need to know kind of up front is what Michael discussed for a second there was Operation Warp Speed, and he showed you the companies that are involved with that. So, and what that means is that those companies are using the government's clinical trials networks. So the government has a lot of say on how those trials are conducted. Unlike Pfizer, that did not use the government's clinical trials networks and did their own thing. So that's important, and I'll talk about that a little bit more later. So initially, the inclusion and exclusion, actually exclusion criteria, which is, tells you who can get on the study and who can't. It was, in other words, it was a bit of a very general, people with chronic diseases that were stable and all that sort of stuff. But then somewhere else in the protocol, it referred to immunologic issues. And then, I got, to tell you the honest truth, I got a number of different stories about how this happened. But, from the outset, it was the people with HIV were not excluded as far as Carl and Tony knew. So, a protocol just doesn't happen. There are many iterations. It gets changed, it gets refined, it goes to IRBs, which are the institutional review boards that review it for ethical reasons, and then it goes to, to the company, to this one, to that one. I mean, it can change 20 times before it gets out the door. Well, this one got changed. All right, and I think that oftentimes companies don't want to include people that have other diseases because it may confound the results. It may harm people with HIV, and then they have to report all of those instances of adverse events and that sort of thing. So I really think that's what happened. They wanted it to be clear and clean and quick and done at warp speed, and too bad for people with HIV. Well, we just weren't really having that, I'm sorry. So Carl was extremely helpful. And Carl dealt with Moderna because they are involved with the government's clinical trials network. And I was more involved with Pfizer because, first of all, Moderna, they're not a happy bunch and they're not used to dealing with us at all. And I think not only were they afraid of us, I think they're kind of arrogant, and they just thought that it would be easier and quicker to do this without the community, any community, us or anybody else. So, you see where that got them, in that they have, both companies have hardly any people of color. And it turned into a nightmare in the long run as far as that's concerned.
Right.
But anyhow, I digress.
Right.
So what we did, because many of these companies deal with the government in Operation Warp Speed or via Operation Warp Speed, I wanted to make sure that this never happened again. Carl was on it from Jump Street, Carl Diefenbach, and he's the head of AIDS, the Division of AIDS at the National Institute of Allergy and Infectious Diseases. So, Carl was so helpful, I can't tell you. It would have happened anyway. It just wouldn't have been so quick, Right. And even that, it really was very harmful in the end, because by the time people with HIV were able to enroll, it was almost time to close the studies. So, but anyhow, that's a whole nother story. So, but then again, let me backtrack a minute. The letter that we wrote, I sent to Francis Collins, who's the director of the NIH, because, as I said, this is government money, this is taxpayer money. What is up with this? We're not having this. So we sent a letter to Francis outlining why people with HIV shouldn't be excluded. I think I sent that to you, Michael,
and
right?
If everyone looks on the screen, you can see here's the beginning of the letter. If you see there, it talks about, we, the undersigned organizations, urge you to ensure that the sponsors of these clinical trials do not exclude people from HIV. There were some parts that I just wanted to show to people really quickly. Like, I love this. There is no clinical justification for excluding people with HIV from COVID vaccine trials. I just love that. And I love this too. The HIV community was promised that there would be community representation and all aspects of these clinical trial developments, but all we see is procrastination. So you did really take them to town in this, and you had pages and pages and pages of signatures.
Yeah, well, see, what I did, I wanted to be sure that we included organizations that represent people of color. So I got in touch with Moises Augusto from INMAC and Guillermo Chacon from the Latino AIDS Commission, and made sure that they were signers up front. So, whenever you do a sign-on letter, you really should have some organizations that have already signed on before you disseminate it widely. This way, it's not like the cheese stands alone. You got
Right.
cover and you see that people are interested in this and it's a worthwhile cause. So I wanted to really be sure that we had organizations that represent people of color, since they're, disproportionately affected and have such horrible disparities with as far as outcomes and morbidity and mortality. So anyway, so we did that. Then I reached out to a friend and we made sure that there were women's organizations that were included. My friend Nelson Virgil, he was after me about this change petition and how we could get thousands of people to sign on and whatever. And I was like, okay, if ever we need it, it's now, and it's got to be, fast and whatever. And Nelson actually did that part of it. He did the, I wrote it up, and he kind of did the logistics of getting it on online and stuff.
Right.
And I have to tell you, in about 4 days, what do we have? Like 1,500 signatures. It was pretty amazing. It's pretty amazing. And then we sent, usually what we do is we send a letter like this to our listservs, and it's all the national AIDS organizations that sign on. So we got loads of them on as well. And then I contacted Suraj Maduri from TAG, and got contact information from congressional, House and Senate reps that were interested in HIV, and everybody's interested in COVID, but HIV as well as COVID. So copy them. It's always good when you have one of these kind of letters to copy everybody in the world. It looks official, it looks fierce, and it looks scary, So that's what I did that as well. And, the thing of it is, when you do some of this kind of stuff, just finding email addresses for all of these people can take you half a day, So it was great to have Suraj, because he's got all this stuff on Excel spreadsheets,
Great.
So that was very helpful. And then I reached out. I wrote to Moderna, but they never got back to us. So what we did was, when we put the change petition up, we put their community person, put her name and her email address, and thought, well, okay, if you don't want to talk to me, you can talk to everybody else.
Mm-hmm.
So I don't know if she got tortured, but there it is. And then what we did was also sent the same letter to everybody that was involved with Operation Warp Speed, and to the FDA's, or I guess NIAID's, Vaccine Research Center. And, two of the people from that research center actually were involved with the development of the mRNA, the messenger RNA vaccine.
Mm-hmm.
So anyhow, that took a long time. It didn't take a long time because we didn't have a long time. So,
right.
It was once you start something like this, it's a real concerted effort, and it's a full tilt boogie sort of endeavor.
Right.
So anyway, we got all of them and hooked all of them up, and Carl, as I said, did most of the work with Moderna. I did most of the stuff with Pfizer. And actually, Moderna, given that they were using these government networks, they got their amendment to their protocol that reversed this HIV exclusion. And we also asked for inclusion of people with HCV, hepatitis C, and hepatitis B. That they should be included as well. And that happened. I was looking at it the other day, maybe a full month, almost 2 months, maybe 6 weeks before Pfizer. Okay.
Mm-hmm.
So, and then I dealt with Pfizer, as I said, and eventually they both amended their protocols. And as I said, the good news is, between Francis Collins, the director of the NIH, and Carl, everybody else on that list that Michael showed you that work with the government networks in the Warp Speed have all committed to not exclude people with HIV. So it wasn't just these two trials. It was a wide range of companies that this ended up affecting. So that's the way we wanted to do it. I mean, we don't want to have to do this every time there's a new company involved.
Exactly.
So, yeah, really. So, you know, it involved speaking to a lot of community folks throughout, you know, getting them to sign, explain, disseminate the letter and all that sort of thing. It was really a community effort. It wasn't just me. You know, I mean, I think Jeff can tell you he was involved in the process all the way through. Everybody was getting copied, and it was a, you know, just a real flurry of activity. I made sure that PACHA, the President's AIDS Council, which was like a joke under Trump, but anyway, you know, that they got it on the agenda for their next meeting. And I really tried to leave no stone unturned. Also, I think something that's really important, I'm kind of the FDA girl. So, you know, throughout our, I mean, I've been doing this for like, God, 33 years. And congratulations, Michael, on 20 years. It's wonderful.
Thank you.
Yeah. Anyway, you know, we're mostly used to dealing with CDER at the FDA, the Center for Drugs.
Right.
You know, because we have what we use is antiviral medications. We've never had a vaccine.
Right.
So for some time, I've been kind of, you know, making contacts at CBER, which is the Center for Biologics that deal with vaccines, you know, just because I deal with a lot of cure research, as do Michael and Jeff. And, you know, we're vaccines, different sorts of vaccines are involved in a lot of those cure trials. So I've been like cultivating contacts at CBER for quite a while. And I got to be pretty good friends with the deputy director. So, you know, in other words, wrote to her, wrote to the director, you know, sent copies of these letters, explained why this shouldn't happen, sent it to other people in CBER that I know that are, they see the problem with the FDA is you have individual reviewers that get these protocols and who knows whose desk it's going to land on. So, you know, we want them to know, and we want them to get the message from on high that this shouldn't be happening. Okay. So, I mean, that meant a whole lot more letters. And, you know, and before you start writing these letters to the FDA, you have to look at what their rules are and what they say. So they actually had a guidance on vaccine development for COVID-19, which I'm telling you, I've had guidances done before or worked with the FDA to get guidances done. And the FDA is one of the most bureaucratic organizations in the government. And it should be, you know, I mean, the people, before they tell people this is how you do it, I mean, it better be right. So, I mean, they're very careful about that. But I'll tell you, this COVID vaccine guidance got done, and it was it was a couple of weeks. It was done. It was amazing and very good. I've been very impressed with the people at CBER. Now that's the biologics, that's the vaccine people and gene therapy and all of that stuff.
Right.
That's what they deal with, as opposed to CDER that just deals with drugs.
Right.
So yeah. So you know, got myself familiarized with the guidance. And because, you know, when you start writing letters and to people that do this for a living, I mean, you should really know what you're talking about. So
Good.
you have to be, yeah, you know, I mean, that helps, right?
Yeah.
So, you know, I mean,
So
I mean, I think, go ahead.
I wanted to ask, so were you happy with the results?
Well, I mean, I wish it would have happened faster, but people with HIV were eventually, after these, you know, these amendments to the protocol were approved, and they had to go through a number of different places, including the FDA, you know.
Right.
So yes, I was happy that they got done. I was happy it didn't happen. I was unhappy that it didn't happen faster, and certainly, you know, really unhappy that it happened at all.
Right.
But the good news is that, you know, it's not going to happen again.
Yes.
At least to these companies working with Operation Warp Speed. And, you know, once this has been done, it won't happen again. I mean, once companies see that it's okay, it's not going to cost them money or time or, you know, confounded data, then, you know, once you get one of these things rolling and it's successful, then it's pretty much done. You know, it's kind of, I mean, nothing's ever set in stone. But, you know, I mean, I think it was very successful. it was a big deal. It took a lot of work and a lot of time. I haven't done anything like this in a good 20 years.
Right.
And 20 years ago, I was a lot younger. But I had a lot of help, and I'm just very happy with the way it turned out. We got a lot of press, so
yeah, I think that's great. And I wanted to ask, have anyone else? Did anyone want to ask any questions of Lynda or Jeff? I think sometimes
just to code it to that, Michael, if I may.
Go ahead.
So after the letter came out and it was official that we were allowed in the studies, I did call the study site back and said, hey, and she said, well, we don't have record of that. And I said, well, you will. I can send you the letter. Can I join the trial? And by that time, as Lynda alluded, they hadn't been enrolling people of color. So she said, we're closed to enrollment, but anybody but people of color, and you can't join.
Oh, wow.
Yeah, no, it was really awful. I mean, and that was Pfizer, right, Jeff?
That was Moderna.
That was Moderna?
Yeah.
Moderna, yeah.
For Pfizer actually added 14,000 people in an effort to get more people of color, but but they never reached out to the community to, I guess they figured they were going to walk in. It's so arrogant, walk in and all of a sudden all these people are going to just come on down. And obviously people that are involved in this know that that's not the case. So.
And could we have everyone remember to mute yourself unless you're talking or you want to ask a question? We have some background noise seeping through. Thank you.
Oh, no way.
All right. So did anyone have a question that they wanted to ask of our two activists?
Yes, I wanted to find out. So there were people who did get enrolled that had HIV.
Yes.
Michael, this is Jeff Shoughton. I was just
Jeff.
That, of the total 72,000 people that enrolled in Moderna and Pfizer, there were 280 who were 280
Can you hear me?
who were.
I gotta get on.
Okay, hold on, everyone, please.
Michael?
Yes, hold on. One at a time. So if we could, please. Whoops, now I've gone there. Okay, sorry, Jeff. Could you go on? And then we'll get to you, Kate, next.
I was just noting that of the 72,000 people that enrolled in Pfizer and Moderna, if you look at the appendix tables, only 280 combined were HIV positive out of 72,000, unfortunately.
And not all of them got drugged.
Right, correct. Yeah, that's the total enrollment. Half of them got drugged. So we don't know anything about how these things work, people with HIV, because not enough people enrolled because of this mess up at the beginning.
Wow.
But Jeff, that is also true. It's certainly true of people with HIV, but it's also true. They gave all these press releases about how it worked with different ages, different genders, different demographics, and that it was all bullshit. The only they had pretty much half men and half women, and that was it. They didn't have enough people of color. They didn't have enough people with HIV. I mean, they don't know anything about how these drugs work in different populations, period. So.
Kate, you want to ask your question?
Yeah, I actually have two questions, and it's not specifically geared toward the HIV community in general, but my first question is, with this vaccine and this new strain showing up, are we going to be protected from the new strain?
Kate,
vaccine?
We're going to get to that at the later part of this conversation. So I'm going to put your question on hold so we can get forward, but we're going to go right back to that. That'll be towards the end, okay?
Can I include my second question, or are you
sure
going to?
Is it? Go
it's
ahead.
not HIV related, so should I wait till you come back?
Yeah, let's wait, and we'll get to it.
Okay.
I promise you.
Okay.
I mean, the other thing too that Jeff alluded to, you're talking about multi-site trials that are all over the country, and Jeff called, and the person didn't have the correct information. Because once I started hearing this, people from around the country were calling me saying, well, they're close to enrollment. And I would call the powers that be, and they'd say, well, no, we're not. So, it depends on how the information gets filtered down from the principal investigator to the study nurses that are answering the telephone. So, I mean, there's a lot of room for confusion and complications, and everything that could have gone wrong went wrong here. With these two trials, and all we can do is make sure that it goes much more smoothly next, with the new trials.
Yes. Okay. So I'd like to move on. I wanted to thank you, Lynda, not only for your work, but for being on our call tonight. And Jeff, I'm so glad you could join us. I hope you guys can hang around as we go through the next, because we're going to be moving on and talking about another of the vaccine trials. Dr. Anna Wald has joined us. She's a UW professor of medicine, epidemiology, and laboratory medicine. She's not only the director of the virology research clinic at Harborview, she is the head of the Division of Allergy and Infectious Disease for the School of Medicine at UW. So welcome, Dr. Wald. And I have your slides here ready to go.
Thank you. So I thought I'll talk a little bit about the Novavax trial, which is also a trial that's sponsored under the Operation Warp Speed. And it is enrolling people with HIV. And at my site, which is at Harborview Medical Center, just kitty corner to the main building where Medicine Clinic is, I actually would really like to enroll large numbers of people with HIV into this trial. And I will go through some of the criteria that we're looking at right now. So I think Michael already went through this, but the coronavirus is covered with these spikes. And we know that the antibody to these spikes blocks infection, and the very positive results from both Pfizer and Moderna, I think, really taught us that that's the right target. So the idea with vaccinating is that the vaccines teach the immune system to make antibodies. So when you then encounter the virus, the pathogen, you are protected. Can I have the next slide?
Sure.
So this vaccine is actually made using recombinant technology. And what they did is that they took the genetic sequence for the spike protein, and they inserted it into a baculovirus, which is not a human pathogen, but it's a virus that infects insects. And then they have this virus insect cells. So then the insect cells make the spike protein that ends up protruding on the surface of the cells. And then they harvest it from the surface of the cells and they purify it. So the spike proteins assemble by themselves into these multi-component little stars that you can see in the middle. And they're combined with adjuvant, so that's an additive that makes the immune system respond better. And this particular adjuvant is made from the soap bark tree from which grows in Latin America. And it's like a detergent and makes it easier for the muscle cells where you inject the vaccine to actually take up the protein. So then, as you can see on your right, then it can become expressed and the antibody to it can form. And then once you have the antibodies, on the right below, when again the immune system encounters the COVID, it can cover it up with the antibodies, and it then can't attach to our cells and cause disease. So that's how this particular vaccine works. And the Operation Warp Speed funded 2 mRNA vaccines, 2 viral vector vaccines, and then also 2 protein vaccines. So this is the first of the protein vaccines. Protein vaccines are a very standard construct for vaccines. For example, your hepatitis vaccine, your tetanus vaccine, your HPV vaccine, they're all based on protein. Can I have the next slide?
Sure can.
Okay. Actually, let's just skip this.
Okay.
I don't think we really need this. So who we're looking for is actually changing pretty rapidly. At the very beginning, when we thought we'd start, which was in November, we actually didn't start. It wasn't ready till January. We were hoping to enroll a large proportion of people who are 65 and older. We're not really doing that anymore because in most states, and I realize that here the audience is not just local, but people have joined from other parts of the US. Many of those people are now eligible to receive the vaccines that have been made available under the EUA. We are, however, still trying to enrich our population in people of color, so Black, Latinx, and other minorities. We actually locally have a satellite site on the Lummi Reservation up in Bellingham, where we're also enrolling. And we're interested in people with any kind of comorbidity, because obviously those people are at a higher risk. And also people who are essential workers of various kinds who are likely to be exposed to COVID-19 and who do not have the luxury of just working from home and not really interacting with the public. So those are sort of in broad strokes who we're looking for. But the truth is that we're certainly pretty much enrolling everybody who comes our way, because the emphasis in this trial has been on speed. The trial started first week of January, really seriously. And out of the 30,000 target, 15,000 are already enrolled.
Wow.
And our site by tonight is going to hit 300. So
really? Good.
yes. So we are doing pretty well.
That's awesome. And here's the next slide for you.
Okay, so this is also double-blind randomized clinical trial. The randomization here is a little bit different than in Moderna and Pfizer, because out of every 3 people that we randomize, 2 of them actually get the vaccine, and 1 of them get the placebo. So you are more likely to get the vaccine than the placebo. There are 2 shots. They're given 3 weeks apart. Oh, look, Jeff Taylor just enrolled. Okay. The initial visit, it says here 3 hours. We've gotten better. I'm down to 2 hours and 5 minutes for the initial visit, but you are in the clinic for a while. We try to make it pleasant. There are 8 visits over 2 years, and 4 of them are in the first 6 months. If you get sick, we also see you, and we have a machine that we're able to diagnose you within a few hours to tell you whether or not you have COVID, and we'll certainly will direct you to get appropriate care. We want everybody to be diagnosed early and do really well in our study. There's compensation for time and effort, and everybody asks, well, what if I get to a point where there's a vaccine that's available for my doctor for me? And, the answer is that we will discuss it with you and tell you what the options are. We are actually all hoping that in the Novavax, we will be able to take everybody who received the placebo and roll them over to active vaccine, so that actually we will have everybody vaccinated. Because my goal is both to keep everybody safe and healthy, and also to maintain the scientific integrity of the study. So we're balancing these 2 issues. I talked to everybody who wants to be unblinded. I talked to 2 people today. They both decided at the end of the conversation to actually stay for a few more weeks in the study, which is terrific. And because by that time, maybe the decision will be that we can roll people over to the active arm. It's not yet there right now. The other thing about this vaccine, which is really interesting, is that everybody who's enrolled thinks that they've gotten placebo, because people have no side effects. So it's so interesting, because when I ask people, like, why are you really wanting to unblind? You feel you're at such high risk? And they go, no, I just feel I got placebo. And then we unblind them, and 2 out of 3, of course, have gotten the vaccine. So, and I see here, Thomas Villa, please, or you can Google me, or we can provide my email. I'm happy if you email me to connect you with our screeners directly to make sure that you get a spot. We're booked out through most of next week already, but people always cancel. So if your schedule is flexible, we are happy to call you in and have you come. Or have you come in later in February when we still have slots. And I don't know if I have any more slides or not. And I should add here that people with HIV are welcome. You have to have a CD4 count above 200 and a undetectable viral load. And you have to just tell us that that's where you are at. We do not ask you for documentation. The medical director for Novavax is Dr. Lisa Dunkel. And in the early 90s, I actually known her from then because she was very active in a development of new antiretroviral therapies. So I know her from those days. She's been actually wonderful. When I email her, she gets back to me within 10 or 15 minutes. So I tend to often go straight to the top and just talk to her if there are any questions about eligibility. But in general, the entry criteria are very broad. You have to have stable disease for the last 2 months, whatever that disease might be. And pretty much everybody is welcome unless you have unstable, you're being in the middle of a workup or something, is happening with you medically. But if it's just the same old, and you've been on the same meds, please give us a call and we would be happy to have you in the clinic. And here's information. New York Times has a very nice story that provides more detail. I'm happy to answer questions about any of this. And let's see, I had a request here from Rachel to show everybody my puppy, but my puppy's out of town on vacation with my daughter.
So did I understand that correctly? That if you already received another vaccine, you could enroll in this study as well? Is that?
No, not if you already received another vaccine.
Okay.
But if you enroll in this study and your doctor then wants to vaccinate you and you become eligible, then we can have a conversation whether or not we should unblind you and then tell you what you got.
Okay.
Assuming that would change your mind about whether or not you'll get the EUA vaccine.
Right. Did anyone have any questions for Dr. Wald?
Can I ask a question?
Sure, go ahead.
Of course.
Yeah, I quickly looked at the HIV qualifications on this study, and certainly I can understand that people under 200 CD4s were excluded, but the idea that anybody with a blip or that had anything over 50 in viral load copy in the last year, I mean, that seemed a little bit stringent to me. I mean, what do blips mean? Nobody really knows. I mean, that happens a lot to people. It would seem like an unreasonable exclusion. Can you explain why that's the case for this study?
I cannot. I'm not a protocol chair. I'm just one of the local investigators. So I think
are you really stuck with that? Can you get around that in any way, or ask for a protocol? In other words, that they oftentimes will allow people in certain circumstances, but are there any exceptions being allowed?
There are no exceptions being allowed if somebody clearly does not meet the entry criteria. This is a pivotal trial, which means that based on the results of this trial, this vaccine will be licensed. For Novavax, this is very important because they don't have any other products right now, and it is very likely that FDA will conduct audits. So we do I think this is going to be a very good vaccine. In phase 1 and 2 studies, the antibody titers were really, really high. So I want to make sure that we do a clean study per protocol so that this vaccine can get to as many people as possible.
Sorry, this is Jeff. I can jump in with my experience because I tried to enroll about a month ago. I didn't try to enroll, I screened, I should say. And the screener over the phone took my information. We had the discussion about the HIV. I sent her my labs, and I did have a blip of about 80. And she called back and said, you can't be in the trial. And then lo and behold, last week, they called me again. I don't know, they conveniently lost those records and treated me like I was new. And I had since gotten more lab work done that was, below 20 and was able to enroll. So yeah, we'll see if the auditors catch them on that or if they manage to just lose it altogether. And
Yeah, it was interesting because initially, actually, they said that we need to show labs, and I actually pushed back on it. And I said, I'm not going to be chasing people's labs. I want to be able to look at them. They look okay. They tell me this is what they've had, a CD4 count over 200, undetectable viral load. That's going to be good enough for me. And I went to Lisa Dunkel with it. And she said, yeah, that seems fine.
Maybe that's what happened then.
Lisa Dunkel is working for Novavax?
Right?
Yes. So you know her too.
Oh my God, she's got to be 102 at this point.
She's been great.
She's very smart.
She's very smart. And she's been really sort of thoughtful and really inclusive wherever I've asked her a question about anybody.
So
I'm glad you joined us.
She's also from the East Coast.
Another battle axe.
I didn't say that. You did.
So do we have any questions about the Novavax vaccine trial? Did anyone want to ask any last questions before we move on? All right, so here is the information. You can send an email to join UW COVID-19 Vax at uw.edu. You can call the number there. That's for people who are here in the Seattle area. And I'm sure if you put Novavax vaccine into a search engine like Google, you'll be able to pull up other places that might be near you if you are from around the country or elsewhere where they might be doing this study. All right. Well, thank you, Dr. Wald, for joining us and sharing this information with us. We appreciate it very much. All right. And next up, we're going to have Dr. Rachel Bender Ignacio, who is the director of the AIDS Clinical Trials Unit here at the University of Washington. She also happens to be the medical director for the COVID-19 Clinical Research Center, as well as being an assistant professor at UW. And she's going to be here to help answer all of our questions. And this is going to get to be a little bit of a free-for-all, but what do we know so far about people living with HIV and the vaccines that are out? Well, from the safety databases from the trials, there's no statistically detectable increase in adverse events for people living with HIV. The efficacy equivalent in people with and without HIV, though, no detailed data has been publicly presented. And as if you remember what Jeff said earlier, the numbers of people with HIV were very limited. 280, I think, is the number that he quoted us. So we might not even ever really be able to get answers like that. But building studies for populations that are immunosuppressed is very important because we have the elderly that we need to take care of. And it looks like that monoclonal antibodies provide protection. And long-term, we might need to do a combination of antibodies and vaccines to help protect that population in specific. We also have these guidelines that are recommendations for people with HIV for prevention, as well as for the management of the disease if anyone catches it. And basically, it's saying in both cases that we should treat people with HIV as we treat the general population, that they are no different than the general population according to these guidelines. And so I wanted to get to the questions here. Just so you know that we have these phases that things are being rolled out, and I didn't know if people understood them. So just so before we get into our questions, there's phase 1A, 1B, and I think that We Are Here needs to be moved over, but I like this graphic, so I kept it, and 1C. So 1A is frontline healthcare workers, long-term care, facility staff and residents. Phase B is frontline essential workers, residents that are 75 plus years, and residents and staff of correctional facilities, homeless shelters, migrant farms, and camps, including police, postal workers, grocery workers, K-12 teachers and staff, child care providers, government, and more. So you get the kind of idea of where we are. Does anyone know where people with HIV fall in these phases? Any ideas?
Can I just add, Michael,
Yes.
that this is from Virginia, and it would have been potentially correct for Washington last week.
Yes.
2 weeks ago when it said over 75, we're now over 65 in Washington. And some of these things are getting slotted around a little bit. So
yes, no.
They're not fixed.
1B also includes people over 50 and multi-generational households caring for grandchildren or nieces and nephews as well.
Yeah. Thank you, Lori. That's correct.
I think for HIV, it just depends on whether or not you meet any of these other criteria. I haven't heard of any.
Right. So granted,
Yeah,
the criteria for 1A and 1B could circumvent HIV, but we were told earlier today that people with HIV are 1C. That's what we were told earlier in another call that was about the vaccines and people living with HIV.
I have a question.
Go ahead.
Because at 1C, if I remember correctly, the resident's 16 and up, but it has to be more than one or at least two underlying medical conditions. If it's just HIV itself, it's probably going to be the phase right after 1C. If I remember, I just looked at the website for Washington, so that's what I wanted to clarify.
So
yeah, you have to have two or more, I think.
And just to round it over, this was some of the phase 2 and phase 3 that were how they were looking at it. So there was the breakdown for the phase 1, but so we're looking at these phase 3s here. So people wrote in lots of questions, and I wanted to at least start off with the questions that were submitted before we got into general questions, and these questions will be gone through. So the first one was from one of our CAB members who wanted to know about blood thinners. And Rachel, do you have any idea of what might be going on in terms of the vaccination and something about people on blood thinners?
I don't have any concerns about blood thinners. I think that for intramuscular injections in general, we do sometimes worry about people having an increased bleeding risk. I worry about this more with a therapeutic injection. So for example, some of the monoclonal antibodies that are being studied are like a 3 cc injection with a bigger needle, a deeper needle, and that would, displace a lot of tissue. Mm-hmm. In general, for most vaccinations, we do not exclude people on blood thinners. These are teeny tiny needles with a small volume injection, and there shouldn't really be a bleeding risk.
Okay.
I haven't heard anything about this at all, so I don't know where that came from.
Right, and again, this person heard on CNN something about blood thinners. They weren't sure what the concerns were, so that's why they wanted to bring up the question. This other question that someone asked was about data collection, and I don't know if you'd be able to answer it, but they wanted to know what could be done to ensure or to require that the collection and reporting of data by all providers and hospitals, basically that it's all done and that this will be accessible for research. Do you know anything about that?
I think that there are some voluntary registries, both for people with HIV getting COVID and for, people are putting together various different registries for people with organ transplants or HIV or cancer, getting vaccines, both for safety. And then there's the VAERS app and website. So there's the vaccine adverse event reporting that's collecting data. But again, I think somebody would have to volunteer that they're positive and, explicitly in linking that to having voluntarily also reported an adverse event. So that's kind of the problem with registry type data collection in general, is it relies on people who have events to report them and then to report the other, the other pieces of data that you'd want to know about them.
Right. And I forgot, Rachel, you had your slides that you wanted to share. Did you want to share them with us?
Sure. Would it be helpful? These are sort of general things about, the screen is moving around.
Sorry. And I'm going to.
I think I need to be a co-host.
Yep, that's what I'm about to do. Just
awesome.
There you go. There you go.
Okay, great. Okay. Oh, you're not seeing my correct screen. Let me see if I can do this. Try that one. How's that? Okay.
There we go.
Perfect. Okay. So I think folks, especially Lynda and and others have covered, sort of the strategies and the kind of ethical ways that vaccine distribution is being prioritized, and also, in terms of kind of vaccine, lack of vaccine confidence and hesitancy, and stopping misinformation. This is from the CDC, not related to COVID. This is kind of their baseline strategy. And again, Michael already presented this. This is the most current, at least in Washington State, phase 1B. You can see I pasted over 65 because that changed last week. And the tier 3 is these are within phase 1B. So 2 or more comorbidities or underlying conditions, I think, could include HIV as one. So if somebody had HIV and hypertension, that counts. I think, kind of critically, whether it's good or bad, it doesn't seem to be that there's validation of these happening. And so it seems to be on the honor system. So I think if somebody reported, I have 2 comorbidities, then that would be sufficient, is my understanding, at least in terms of seeing how the over 65 and some of the other tiering or vaccine access is happening. Mm-hmm. So I just wanted to talk a little bit about the 2 currently available vaccines. Is that helpful, or do people feel saturated with information about these 2 vaccines?
I assume since no one's complaining.
Go. Okay. So these, again, have the emergency use authorization. So that's not a full FDA approval, but really nothing right now has a full FDA approval other than remdesivir for hospitalized patients. That's really the only thing. So Pfizer and Moderna are the makers of these, as everyone's already mentioned. Pfizer did this outside of Operation Warp Speed, and Moderna within Operation Warp Speed, with really cool fun fact. Kizzy Corbett, one of the relatively young Black woman scientists at NIH, was the one who did a lot of the science of this vaccine before it was handed over to Moderna. So follow her on social media if you don't already. She's amazing. So these vaccines are really made out of the messenger RNA from SARS-CoV-2. So it's a non-infectious piece. It's just the blueprint to make the protein, to make the spike protein of SARS-CoV-2. I've seen a bunch of chatter on Twitter about whether or not, for people who are living with HIV, is this dangerous, because could the reverse transcriptase then get this into your own genetics the way HIV can reverse transcribe itself? And the answer is no. This mRNA does not enter the nucleus and doesn't interact with any of the proteins or anything from HIV. So I think that was sort of a bad rumor or false concern going around the internet, but it's valid, and wanted to make sure that was addressed, that this vaccine does not get encoded into your cells, even if you have HIV in your cells. So it's just this little messenger RNA, and then it's packaged into like a little lipid spherule, and with also polyethylene glycol, which is what's in Miralax, or the stuff they give you before a colonoscopy. So it's kind of a little polymer. We think that people who have allergies to the vaccine are probably having an allergy to the polyethylene glycol, and that if you've taken Miralax or Go Lightly before, you're probably good. There is some little concern about cross-reactivity with sorbitol, so for people with a sorbitol allergy. That said, the vaccine does not have any live or any dead virus, so it's completely safe for everybody, no matter what your immune status is. Unlike other vaccines, and there are SARS-CoV-2 vaccines, for example, there's a Sinovac one, and there's several other ones predominantly made in China, and then the Sputnik one, I believe, are like a live inactivated SARS-CoV-2, and those may need to be used with caution in people who have a depressed immune system. These ones, again, not infectious in any way, either to the person getting the vaccine or to household members. It's another question I've heard before is, my partner's getting a vaccine, can I be in the same room with them, or are they shedding vaccine virus? And the answer is no. That would be different from, for example, the old chickenpox virus vaccine, which you could actually shed and could be infectious to somebody else who's immunocompromised, living with them. There are no preservatives, egg, latex, mercury, none of the other stuff that people worry about with some other vaccines. And the really important thing to remember, and I highlighted, is that both of these vaccines decrease the relative risk of symptomatic infection for 95%. So that's not the absolute risk. I've seen a lot of this again, and I'm just trying to go through and kind of debunk weird media stuff I've seen. A lot of people are saying, well, if there's a 1% chance of dying from COVID and the vaccines prevent you 95%, that means that there's 1% chance I die and a 5% chance the vaccine doesn't work. That is not how statistics work in this case. Vaccine efficacy is compared to people who are not vaccinated. Your risk is 95% lower, which means, and it's probably even lower. So it decreases your death rate probably by 95%, hospitalization rate and symptomatic disease. And it may be even more than that, because it seems that the breakthrough cases, people who get sick after getting these COVID vaccines, have predominantly had mild illness, and it's preventing the severe illnesses and hospitalization. So that's really, really important. What we do not know yet is to what extent it prevents transmission. We suspect that it does prevent transmission by quite a bit, but we don't know if that's 50%, 70%, 80%, 100%. What we know about a lot of other vaccines is that they may allow you to still get infected with the virus, but that maybe it limits it to an asymptomatic infection of the mucosa of your nose and mouth. And then because you already have antibodies and T-cell responses from the vaccine, you abort that infection before, you get a cough or it's actually making you really ill. But that might mean that maybe you have, 2 or 3 days of low level amount of virus that you're shedding and could make somebody sick. But I think our hypothesis would be that you're infectious for a shorter period of time and probably less infectious per day, because it'll probably be less viral shedding. But the answer is it's probably not 100%. And so that's kind of all of those questions of like, do I still need to wear a mask if I've been vaccinated, et cetera. So how these two vaccines work, this is just a cool schematic made by Moderna, but the Pfizer vaccine is the same. This is this little lipid formulation with the messenger RNA inside of it. When it goes into your arm, it's actually your muscle cells. And I didn't think about this initially. It's the work at the beginning is not being done by your immune system. It's being done by your muscle cells, who are making all those photocopies of the protein, the spike protein. And then your muscle cells are releasing that protein into that surface where it's picked up by your immune cells. And then these are just various pictures of the different types of interactions between T cells and B cells that are picking up those viral proteins, the antigen, and learning about them. So not only do these vaccines make antibodies, but they also make a strong T cell response. You can see there's a CD4 T cell down here and a CD8 T cell here that are learning how to make really strong T cell responses, which is really important to being a good vaccine. So why is it important that this work is happening in your arm? Because most people who get this vaccine will be dang sore for a good day or two after they get vaccinated. And that's just because those muscle cells are doing the work. And then what we're often seeing is that people who get vaccinated at their second vaccine, after the second vaccine is when, if you will have symptoms, that's when people tend to have fatigue or muscle aches, or some people are having headache, fevers, nausea. I personally got 2 Pfizer vaccines, and with my second one, had a hard time getting out of bed the next morning and went to bed a little early the night that I got it. Felt pretty sluggish the next day, felt a little better after some Tylenol, and 12 hours later, I felt perfect. I didn't have any fevers or chills. Lots of people have. But the way I think about that is that's just all this stuff that you see here. That's all of that happening. That's your immune system learning about this. This is not a dangerous thing happening. This is not, oh, maybe I should have just gotten the virus itself instead of the vaccine. This is your body doing the work. And I was happy to remind myself of that when I felt a little crappy the next day. We also do think that people who, or have some idea that people who were antibody positive for the virus, when they first got their vaccine in these studies, may have had that reaction more with the first vaccine. And if you think about it, it makes sense, because it means that your first vaccine is like a booster instead of the second vaccine being the booster. So just be prepared for that, especially if you know that you've already had COVID, that you might have that kind of, flu-like symptoms for a day or two afterwards, after your first vaccine. And otherwise it may happen after your second one. This is actually Tony Fauci put this together and just published it just as a kind of a review of these vaccines. this is the way we like to see science presented. You don't even need to know statistics to just look and see that like there's a screaming big difference between vaccine and placebo for both of these. And it's actually pretty much the same. On the left-hand side of the screen, you'll see those little purple triangles. Those are people who had severe illness and or leading to hospitalization. So you see one person in the vaccine arm ended up with severe illness, whereas a whole bunch of people in the placebo did. And then you can see that after the first, even as early as 7 to 14 days after the first vaccine, very few infections are happening in the vaccine arm. So this is a win in my mind. This is like as good as it gets. So cautions with these vaccines. Who shouldn't get these vaccines? We're really saying that the only people who shouldn't get these vaccines are people who've had anaphylaxis to the first vaccine, specifically this vaccine, or PEG is that polyethylene glycol or Miralax or sorbitol type thing. People who have a history of other severe allergies like food allergies or other medication allergies are encouraged to be observed for 30 minutes instead of 15 minutes because most of these severe reactions happen within minutes, on average, I think about 12 minutes after the vaccine is given. So most people, they're having sit in some chairs and just hang out and be monitored with nurses for 15 minutes. You get a 30-minute observation if you have that history. Again, there's no concern about cross-reactivity with peanut or egg allergies or any of this other stuff. And most of the people who had reported anaphylaxis were really not a serious infection. It was something more mild. Again, no concern in people who are immunosuppressed. So many people have heard maybe they shouldn't get an MMR vaccine or the old shingles vaccine or the yellow fever vaccine. That is not a concern. The CDC also continues to recommend these vaccines for people who've had Guillain-Barré before, either to another viral infection or to a vaccine, or people who've had vaccine reactions to, for example, a flu vaccine, because these are completely unrelated. Anna covered the Novavax vaccine. The AstraZeneca vaccine is made in an adenovirus, and as is the J&J one. Neither of these are approved vaccines, but they're probably coming soon. Sorry, this is a slide deck I used for doing a presentation in Spokane, so they're enrolling in Cheney, and that's it. I will stop there and just see what other questions folks had.
Yeah, did anyone have a question you wanted to ask? I know Kate had a question, but she, I believe, had to sign off.
Do you want me to?
I have a question, Michael.
Go ahead, Larry.
So I just wanted to, or a comment anyway, that there's that list of providers for the vaccine. So I have contacted many of them. Generally it looks like they don't have anything. I mean, the best I was able to do was supposedly get on a wait list for Virginia Mason. You never end up talking to a human. It's all done on the web. And anyhow, right? At least places that I've tried. So.
Yeah, I think in this very moment, Larry, you're right. I think that there is very little vaccine available right now. This is part of this issue where, states were scheduling out their vaccines based on being told that there was another stockpile coming towards them, and then the federal stockpile was exhausted. So this is, classic failure of the previous administration to be accountable or do anything functional in my mind. Staying out of politics, but not really, because it's not possible to with this. So I think that people are trying to do as well as they can. And, it seems to be kind of popping up in different places. And so I would just be persistent. And, if you're on your primary care provider's call list or just having your eye on it. I know that there's going to be some kind of pop-up big events happening in parking lots in the South Puget Sound area. I think in like Kent and Federal Way and other places, they're trying to get vaccine out to people.
Go there and stand in between the cars?
Sorry?
I see these mass vaccination places on TV, and everybody's driving a car. I don't have a car. I couldn't.
Yeah, how do you get to them? So exactly. So I think the idea is that those ones down south are for people that live in those areas. But you're right. This has been part of the failure of the last mile delivery from Operation Warp Speed, which I understand Operation Warp Speed is not actually called that anymore as of the new administration. But at least this is the rumor that I've heard. Although we're still calling it that on our treatment calls. You're right. It has to get to people. So far, what I've heard from people in all sorts of places is that this is being, people who are internet savvy, who know how to sign up, who are persistently hitting refresh, who have a car, who can drive out to these are the people who are getting a vaccine. And there's a very strongly worded letter going into ACIP for tomorrow's meeting, talking about how we need to do better on getting it into at-risk communities in where they are and not, at the airport.
So really, you need to be skilled with the computer to get through these.
Skilled with a computer, be able to drive yourself, read English. There's a long list of ways that so far the distribution hasn't worked.
Yeah, I find it frustrating when you go to a site and they ask you all these questions, which is the same questions you ask just to start the whole process. And then you go through this thing and then eventually figure out that they must not have any vet, but they don't generally even say that. It just, like Safeway asks you it says that to go beyond this point, you have to pick a date and time. And if you go through their calendar, for every single month, it says there are no, no availability for January, February, March, April,
Larry, it's because there was yesterday or there was the day before, but not yesterday. This was why we need a national distribution plan with community level implementation. And I think it's coming, but I think that, I think we all agree with you. There's been a full national uproar from every sort of strata of society that this is not working. The ACIP meeting is tomorrow. It's open for public comment. I think needs to be submitted by tomorrow at some point. If anybody feels like writing a public comment, whether on, prioritizing people with HIV or just, again, general community accessibility. Yeah.
Okay.
We're with you, Larry. This is.
Yeah. So also, Rachel, I've had people ask me because they've heard that antiretroviral medications some of them are contraindicated.
100% untrue. There are no medications contraindicated. I'm also wondering about the turning away from the vaccine. I wonder if this is from vaccine studies and not from vaccine, distribution. That if, folks like Jeff's story about being turned away from a trial, or I know, David Malebranche, who's a very, I think, public figure on Med Twitter, who's a positive physician, HIV physician himself, tried to sign up for the Novavax study and was told that people with HIV weren't allowed. But that wasn't true because that wasn't per protocol. So I wonder if the stories are coming from studies and not from implementation. That said, I think that if people are asking, I've heard a lot of mixed stories about people asking their primary care doctors, should I get the vaccine? And primary care doctors maybe not being sure whether or not it would work in somebody who's immunosuppressed. There's actually a really good info page. I was just looking at Seattle Cancer Care Alliance has a really good Q&A about, should people undergoing stem cell transplant and chemo and all that stuff, should they get vaccinated? And I think they wholeheartedly said yes. But not all people feel, or not all providers may have given their patients the answer yes, because I think they may just not be sure that when in the course of treatment or something, somebody should get a vaccine. So there's nothing official. Nobody should be turned away. All antiviral medication should be fine.
There was another question someone asked in the chat about one-shot vaccines. Do you know anything about those?
Yes. Oh, actually, sorry, I should say the antiviral medications that you should not take getting the COVID vaccine would be the monoclonal antibody for COVID. So
Okay.
people who are getting monoclonal antibodies for HIV, who are participating in an HIV study, getting BNAbs should be totally fine. The CDC has recommended that people wait for 3 months after getting, for example, the Lilly or Regeneron SARS-CoV-2 monoclonal antibody, both because you're protected from those passive antibodies and those antibodies might neutralize the vaccine and not allow you to then make a good vaccine response. So that may be what somebody was hearing. That said, I should also mention that the ACTG and DAIDS has come out very firmly to say that while EUA drugs and vaccines are often considered experimental and are therefore excluded from people who are on studies, like on an ACTG study, we are saying very firmly that these are not experimental vaccines, and that people who are on any ACTG study other than the SARS-CoV-2 studies should not be precluded from getting a vaccine while on study. No, you do not need to know your CD4 count or viral load.
Cool. And also, I remember Kate's question. She wanted to know about the newer strains that we're hearing all about.
Yes, the new strains. So just a gentle reminder, I think our folks think about stigma and stuff a lot, but we've talked a lot about the stigma of associating SARS-CoV-2 with China. The news media has not caught on to this at all and is calling B117 the UK variant, as if like that's okay because, I don't know, it's from Europe or something. And then there's a new strain that has come out of South Africa called B1, what is it called? I'm blanking. B1351.
Right.
All of the vaccines that are available right now have been tested against these new strains, and definitely the B117, the two vaccines have high efficacy against. The B1351 it's possible that it has a lower efficacy against that one. It seems like it still works, but it may not create such a good response against these new ones. That said, I think with all of these issues, with the different variants and things, they're hot in the news. We don't know enough about them. I don't think it's worth our time worrying about them as individuals, other than to say we should do our best public health practice things, distance, masking, being vigilant, and getting vaccinated. The data is coming on these, and there's just, I think, a lot more in the news than there is science right now.
Do we think that there's possibility that people may need to get some kind of a booster later on to be able to respond better to the newer variants? I think I heard that Moderna was looking at making some changes in their vaccine to make it more robust.
Definitely, Lori. I think the answer is likely. So first of all, it's well known that for any respiratory virus vaccine, oftentimes we don't make good antibodies and good responses to these systemically after a natural infection anyways. And so we may not make, immunity that lasts longer than a year, for example, and in which case somebody might need a booster just to up the immunity against the same strain. But because we're also seeing mutations in the virus, it may be sort of similar to a flu vaccine, where each year they come out with a new seasonal flu vaccine where they actually change the composition of the vaccine to adjust to what's circulating at the time, and could even potentially put sort of different strains in it all at once. That's kind of the great thing about these mRNA vaccines, is that they're kind of plug and play. And so my suspicion is that we'll probably need to get one of these every year, either to augment our immunity once a year or to adjust to what's circulating, or both. But yeah, I think also to sort of reduce some of the concern or hesitancy that people have about how quickly these vaccines were developed, they plugged the SARS-CoV-2 mRNA into these vaccines But the technology, this how to make an mRNA vaccine, has actually been in development for over a decade. They just hadn't successfully made one. So it's kind of this cool technology. It's like this shell and this way of doing it. And then they can just drop in the genetic material from whatever they need to. So my guess is that they're going to start making these that potentially have a bunch of different strains loaded into them that adjust to what's out there.
Yeah, I had heard that they were thinking that you might not need to get, that annual shot, that this, because it's messenger RNA, it might give you longer protection. Are there actual studies right now where where they are monitoring people to see how long the response lasts so that we would know if we needed to get revaccinated?
Yeah, 100%. They're right there with you, Lori. I think we've just passed the 1-year anniversary of the first infection in the United States, and we're now 13 months from the first infection in China. So the answer is we just don't know yet. But certainly these vaccine cohorts are following participants for up to 2 years and continuing to redraw their blood and look at antibody titers, and in some of them T cell responses and things like that. To be able to find out exactly that question. So I think anybody who says I think the correct answer is we might, or it's possible based on what we know. Again, it may be that the immune response to that strain is durable, but they may need to slot in an additional strain because of what's circulating.
While we're talking about this, someone's asked, could we use this mRNA technology against HIV in terms of a vaccine?
So we don't know. I think people have been looking at it. I think part of what has been, there's so many reasons why HIV is like the most tricky virus to find a vaccine for. One of the things that we know from, specifically the STEP study, which had an Ad5, so an adenovirus 5 vectored vaccine, so it's kind of similar to the J&J vaccine or the AstraZeneca vaccine, and how it's built, where they take an adenovirus that's capable of replicating, the adenovirus is, and they take out part of its genome, the part of the genome that would make you sick, and instead they plop in a piece of SARS-CoV-2. Well, they did that. That was the STEP vaccine, or the Pombilli vaccine that they did for HIV, and that they found that the process of evoking that strong immune response that they thought would help create immunity actually increased the risk of some people in the study of acquiring HIV because that activation of the immune system sort of made somebody inflamed and therefore vulnerable to infection. And so I think that's the trick, is sort of how do we tickle the right cells without turning on this other response that could actually create a vulnerability. I know that it's being studied. I don't know that it's actually gotten into humans with HIV in it, or what they need to do. Obviously, you'd need a really strong both CD4 or CD8 response, more than antibodies probably.
Right. And so,
Michael, this is Jeff. The HVTN will be starting an mRNA Moderna HIV vaccine trial, a phase 1 in the first quarter of this year, is my understanding.
Oh, great.
Oh, hooray. Thanks,
Looking
Jeff.
at this mRNA technology, apparently folks have been advocating Moderna to get into this field for a while, and now all of a sudden they're very interested in it with the success of this approach. This is the first mRNA technology that's been proven to work for human vaccination. So there is work going on to begin a phase 1 study in HIV. And I'm not sure what protein, though, because those proteins change so much. It's a much more difficult target, like Rachel was saying, to target. But there is a phase 1 study coming up soon, is my understanding.
That's great. I wasn't sure of that update, so thank you so much, Jeff.
Yeah, that's great to know. I also wanted to just bring this up because I thought this was important. Immunocompromised. And we just heard it earlier this afternoon, where some people living with HIV feel that they are immunocompromised, and others are look at them as not being immunocompromised. And I know there's some sort of shades of meaning that we might be able to help people understand. Could you help us wrap our heads around that, Rachel?
Yeah, sure. So, I mean, I think we could start with sort of the empiric data of what we know. So, I can find the link. Michael, did you see the AIDS map article that was published this weekend?
I think I did. Which is it about the 350?
Yeah. Oh, yeah. Sorry, you sent it to me. Of course.
Yes.
Yeah. So in a big review of people with HIV in Europe, they found that the risk of having severe COVID-19 was higher in people who were had a CD4 count below 350. I can say sort of informally that we have some preliminary data. We're looking at this as well in the United States, and I think that kind of agrees with that as well. And I know that I think Raj Gandhi is giving a talk about this specifically, kind of HIV and COVID, and then I actually also Adrian Shapiro and I authored there's the IDSA and CDC came together to make this COVID real-time learning network page.
Mhm.
And Adrian Shapiro here at the UW and I are the scientific editors for this page. So I'm including the link to everybody. It's has science, it has guidelines, it has, kind of everything that people might want to know about what it means, at least what we know from published literature about COVID-19 for people with HIV.
And there it is.
And, well, thanks for bringing that up. And so I think the trend is to sort of say that people who have low CD4 at 350, that seems to be the increased risk. Honestly, as we know now, most of the, the sort of historical data on immunosuppression was based on CD4. But what we actually are understanding these days is that many of those things that we thought were risk was because when there wasn't treatment for HIV, everybody was not virally suppressed and a CD4 count only went one direction. And we're now coming to understand, obviously, that many of the things that we associated as risk with CD4 thresholds are no longer necessarily risky at that CD4 count if someone's virally suppressed, if that makes sense, right? So we've understood that for PJP pneumonia and for MAC, for example, that a lot of that risk that we associate with a low CD4 count goes away if someone's virally suppressed, even if their CD4 count's still pretty low. Just thinking that immune exhaustion, sort of your immune system getting pooped out from constantly responding to the virus, may be actually more detrimental to your ability to respond to other infections than not having a whole ton of CD4 cells. So that said, we're looking at that data across CFAR sites here. We may actually have a hard time, though, trying to understand whether it's having a suppressed viral load, which we're counting as under 200, not undetectable, because again of what some folks, I think was it Lori that brought up the idea of blips and the meaning of blips, et cetera. So blips notwithstanding, people who generally have virologic control, your immune system is not constantly exhausted. And so therefore the CD4 count may not be as important. The problem or the not problem is that in our population in Seattle, we actually had very few people who were not suppressed. And so when you do statistical analyses, you need enough people in both boxes, and we had very few people in the not suppressed box. So that's actually good news.
Well, this website is really great.
In that same AIDS map article, they noted that in the study, it appeared that people whose nadir CD4 count was extremely low did have worse outcomes. In fact, it was linked to an outcome of death. Do you have any insight into that? And that's nadir CD4 count, not current count.
Yeah, exactly. I think that's a great point. We have found those associations in a lot of things. Actually, there was a something published in an ACT study
now.
just I think this month. Just this month that looks at the risk of multimorbidity, meaning people having more than one comorbidity and found that the current CD4 count was not predictive, but the nadir was, and also the CD4 CD8 ratio. And so I think oh, sorry, am I unmuted now?
Yeah.
Okay. So I think it's clear that there's immunologic memory, and that it may be that part of that immune exhaustion or the ability to come up with new naive T cells to respond to new things that you haven't seen before can be depleted in people whose lowest CD4 count was very, very low. So I think that finding in that AIDS map article is consistent with what we know from risk of cancer, risk of non-AIDS comorbidities, and a lot of other things. So I think that's hard to address in retrospect if somebody was low in the past. I think that's why we're looking at obviously different immune therapies to see if we can kind of reverse some of that long-term damage in addition to cure research. But yeah, all I can say is that it's sort of in line with what we know about other problems.
Would you consider that a reason to sort of jump up the priority level of people who have had a previous extremely low nadir count, and or would you consider that a factor in approaching treatment for someone who does get COVID-19 in a more aggressive manner?
Great question. So I think there's been a bunch of advocacy work. Obviously, you all know better than me about, approaching ACIP and trying to kind of increase where people with HIV are on the risk stratification, and specifically maybe not if it's just all people with HIV, but specifically below 350, similar to what the European Union has just done. It is based on current CD4 count. I don't know if, I think it would be hard to validate nadir in terms of, I think, honestly, what we're trying to push for, and what this statement that my colleagues and I, some of whom are at HIVMA, but obviously we can't formally advocate from that as an institution, is to get rid of some of these kind of picky criteria that are like this but not this, because what means that happens is that they reserve buckets of vaccine for different types of people. And what we really need to do is connect people to vaccine and vaccine to people. And so, if you have to go through and show your doctor's record of what your nadir was, all that's doing is slowing down the system and making it less accessible. And so I think, what a lot of us are saying is that this kind of really tiered, fancy approach of like this, but not this, and you work in retail, but it's a convenience store and not a restaurant, or you're a bus driver, but not a police person, and you have hypertension, but not diabetes or whatever. All this does is serve to probably slow down and make it, inaccessible for, especially for people who don't have internet access or documentation. And it should, my mind is to just say, I'm at risk, like put this vaccine in my arm.
You have a little someone who appeared.
I'm fine. You either need to be on screen or off screen. Do you want to wave to the community?
Hi.
That's Miss Nora, who's going to be a scientist when she grows up.
All right. Any other questions for Rachel before we wrap up for today? So I wanted to thank you, Rachel, for taking the time to explain all of these things for us. I know that people had lots of questions, and I hope all of you have had a chance to get some of your questions answered by participating today. This will be posted for your reference onto our Facebook page. I'll probably do that sometime tonight or early in the morning, tomorrow morning, just so you know. I will also try to make these via email, the links that Rachel just shared with the ID Society here, because that looks like a great COVID resource for many people. So I wanted to thank you all for joining us, and thank you to our presenters, Jeff and Lynda and Anna and Rachel. You were all wonderful, and I want to really thank you for taking the time to talk with us today.
I'd say also, if folks have questions, I just put my email also in the chat. I'm really excited to be the directing the ACTU now, and I look forward to talking more with you all. If folks have questions about vaccines or non-COVID stuff, just, obviously everybody reaches out to Michael all the time, but I just wanted to put my email out there as well. I'm happy to chat with anybody.
Great. Thank you. And thank you all. It was good to see you. And I hope to see you all again next month and hopefully one day in person again. Take care, everybody.